let's get started now. It's going to be a small class then. Can everybody hear me?
Em nghe được ạ.
Okay. All right. So we'll have this as since it's a small class, we can have it as an interactive class. If you need me to repeat something or have questions, feel free to stop me. I don't have to go straight through, okay? Well, those who don't know me, my name is Myhanh. I'm a nurse practitioner currently working with Kaiser. My clinical background is plastic surgery, ER, and I'm currently doing pre-op. So much less stress and no crazy hours like the ER. So it's quite a change. So for almost 10 years now, I've been volunteering with the Cleft Lip and Palate team. I started out with international surgical missions. They are now known as Operation International. Did that for a few years, and I joined Project Vietnam mainly as a volunteer of the leadership role, for example. So the purpose of this class is just to teach you a little bit about nursing care of the patient with cleft lip and palate. So in the future missions, hopefully it'll inspire you to join us on your future missions. Ask me. I'm not going to go into too many details, more of a general knowledge of cleft lip and palate, okay? So what is cleft lip and palate? Cleft lip and palate is a partial or complete separation of the upper lip, the gums, or the palate, which is underneath, on top of the tongue here, caused by failure of the middle and the side portions of the upper lips to fuse during development of the face. It's the most common craniofacial malformations in the newborn. We do have a lot of them, and actually a good number of them in the United States. It's just that it's not as obvious because these children often get fixed pretty early on. As early as 10 weeks is when they get the lip surgery. Prevalence in the United States, like we said, the National Birth Defects Prevention Network is what they use to track these birth defects. The incidence of oral cleft lip and palate in the United States is 1.45 per 1,000 live births. So that's about 1 in 690 births. Cleft lip alone is about 0.3 per 1,000. Cleft palate with cleft lip is 0.5, and cleft palate alone is more common. It's 0.59 per 1,000 live births. Put my sources at the bottom if you want to read further, okay? Cleft lip and palate affect boys twice as often as girls. Isolated cleft palate is more common in girls. 75% of them is unilateral, meaning it occurs on one side, and it's usually on the left side. So with this statistics, when you go to Vietnam, a lot of the kids look alike. You can't tell if they're boy or girl. If they have a cleft lip and palate, chances are they are probably a boy. If they have just a cleft palate alone, chances are they're probably a girl. I've tried that trick on, and it's helped me along the way. Vietnam, oh, sorry here. Did I just jumped? Okay. Vietnam, there's no national birth defect database. Disease reporting in Vietnam is composed of multi-tier government networks with priority on vaccines, preventable and infectious disease, and traumatic injuries. Plus, the reliance on paper medical record leads to a lot of challenges in data collection to accurately calculate the incidence of cleft lip and palate in Vietnam. In 1998, Natsumi conducted a study on Vietnamese cleft lip and palate malformation with their surgical mission team. And they reported a prevalence of about 1.49 in 1,000 live births, so very close to the incidence in the United States. In 2001, has had a study conducted at the Vietnam National Children's Hospital, which is a pretty large pediatric tertiary care center, serving about 12 million children. This study report cleft lip and palate prevalence of about 1 in 1,000 million. So the numbers are pretty similar to that of the United States, except for we don't see them too often in the United States, again, because these children in the United States often get treated pretty early on. So you'll see large cleft lip and palate walking around by age 8, 9, 10. They're usually fixed within the first 3 months of life. Embryology, the cranial facial development presents a complex interaction of cell pattern, migration, proliferation, and of course, differentiation. Much of the facial tissue originates in the cell migration from the embryonic neural crest, which is the pretty much early on here. Normally complete closure of the lip is accomplished by 35 days post-conception in the lateral area, which is highlighted in blue. In the medium, the yellow and the green area here merge later on. Failure of the closure at any one of these normal sites of fusion can produce unilateral, bilateral, or median cleft lips. Okay, so mainly these blue, yellow, and green parts needs to merge, and if they don't, for one reason or another, whether it's cell differentiation issues, then that's why you get the cleft. Okay. So far, so good. Any questions? Okay. Cleft palate occurs when the midline fusion of the palatal shelves, the green area here, fails to occur, where they don't meet together. Okay. Abnormalities in programmed cell death due to lack of palatal fusion. Although this mechanism remains debated, cleft palate can occur with cleft lip alone. The latter is possible because the palate closure is not complete until 56 to 58 days post-conception, while after the closure of the lips, and because the etiology may differ. So chances are by the time the woman realizes that they are pregnant, their child has already had cleft lip and palate. So by that time, pretty much nothing we can do. Etiology, most oral cleft lips are non-syndromic, genetically complex event with the gene and gene environment interactions. Okay, non-syndromic means it occurs alone and it doesn't occur with any other deformalities like heart or developmental issues. Genetic, the process of mid-phase development involves genes that control cell pattern, cell proliferation, and extracellular communication. And gene variance in any of these developmental processes is crucial to mid-phase development and has been associated with development of clefts. So some genes that have been implicated include SABT.
So anyway, either, huh?
You're right.
Hi there. If you're not going to be asking questions, can you please turn off the microphone?
Please turn off the microphone.
Okay. So environmental factors that contribute to cleft lip and palate include some drugs, anti-seizure medications such as phenytoin, a lot of the seizure drugs here, valproate, topramide, folic acid antagonists such as methotrexate. Patients taking these drugs should work with their clinicians to continue use, if possible, and partially during the period of organogenesis. So very early on, before they even plan to get pregnant, they should discuss with their neurologist concerning the concern for birth defects and their seizure medications. Okay. Cigarette smoking, maternal smoking increases the risks for cleft lip and palate. Tetranogenesis has been attributed to hypoxia as well as component of tobacco. Associated between passive smoke and smoke exposure and oral cleft lips. Okay, folate deficiency. Several studies suggest a causal link between folate antagonists, anti-seizure medications, and higher risk of cleft lip and cleft palate among exposed fetuses. Maternal use of folic acid had been associated with a reduction in cleft lip and palate and a non-significant reduction in cleft palate. Folic acid is normally found in a healthy diet and is usually recommended for supplementation for female of childbearing ages thinking of pregnancy. Unfortunately, nutrition is a big issue in Vietnam, so maybe that's one of the contributing factors for the Vietnamese cleft lip and patient. Maternal obesity has been associated with small but statistically significant increase in several congenital anomalies, including oral clefts. Others, exposure of other agents such as viral infections, radiations, and significant metabolic perturbations such as poorly managed diabetes has also been associated with clefting. However, evidence supporting and refuting these associations is a little bit of conflicting, okay? Syndromic cases, syndromics accounts for about 30% of the cleft lip and palate and 50% of cases of cleft palate. Just quickly going through some of them include the van der Waals syndrome, causes cleft lip, cleft bones. The child has a flattened face, unusual eye developments, craniofacial abnormalities, and cleft lip and palate. Trichocolon, we have a patient like this in 2018. If you've seen one of our documentaries, she has cleft lip and palate, very distinctive eye. She has no eyes, what is this? The cheekbones. Yes, she has no cheekbones. Usually the eyes are drooped down because of the no cheekbones. The lower jaw is really small. In addition, they also can have cleft lip and palate. Again, DiGeorge syndrome, orofacial digital syndrome, Pierre Robinson syndrome. So it's lots of causes for cleft lip and palate, okay? Clinical manifestation. That means what happens to these kids or what difficulties they face as a result of their craniofacial difficulties. They have difficulties in feeding and swallowing. It's difficult for the baby to form a seal to suckle milk from the bottle or breast. It's like almost like trying to drink milk from a straw that has holes in it. It's really, really hard. Newborns can easily choke on liquids with potential for liquid or foods to come out of the nose. It goes up into the sinuses, okay? Velopharyngeal dysfunction, which is a nasal sounding speech due to the inability of the soft palate to poorly close off the mouth from the nose while speaking and letting air escape through the nose. So these children often have speech difficulties. If they do speak, they sound very nasal, okay? Em hay nói ngọng á. Hearing impairment, abnormal reflux of food and fluid into the nasal cavities and the sinuses. It can set up for chronic inflammatory changes around the eustachian tubes and breaks the barrier between the mouth and the nasopharynx, and it causes changes in the bacterial flora resulting ear infections. So ear infections, speech, feeding issues are the major problems, not in addition to, of course, the cosmesis issues and the social issues that we have to help these children for. Any questions so far? Comprehensive cleft lip and palate treatment plan. Early on, during the 1 week to 3 months, so at least in the in Vietnam, they have programs like this too, where they have orthodontic molds put into the mouth to help kind of bring the help with the feeding, but also help to bring the separation closer together so that they have better results when they have these when they have the surgeries. Like this is before the orthodontic. Now what's they called is a nasal alveolar molding device. You can see a nice big gap in it, and then this is after the device. So the gap is much smaller. So when we do surgery to put them together, it's not so big of a stretch. So not so much of a resistance, and cosmetically it'll look better. As you can see, the nose is lifted up also, okay? Cleft palate repair, we usually do that between 3 to 6 months. Surgeons realigns the muscle of the upper lips to provide normal lip function and to facilitate suckling or breastfeeding. Primary nasal repair is often done at the time of the cleft lip repair. So they make an incision, they put the muscles together before they put the skin together in a cosmetically pleasing way, okay? We use the rule of 10. The child has to be at least 10 pounds or more in body weight. They have to be at least older than 10 weeks. and have to have a hemoglobin of 10. That's the minimal criteria needed for us to approve them for surgery. And that's the kind of the standard of care for cleft lip and palate in general. Okay, so. Comprehensive cleft lip and palate treatment plan. Next part, a cleft palate repair. We usually do this at 1 year or 9 to 18, 9 months is the youngest we'll accept them. The repair to bring the gap. Okay. Okay, come on, don't tell me my internet connection is unstable. Okay. Palatal expansion. Palates in patients with cleft tend to be narrow and collapse. Palatal expansion prepares the patient for subsequent bone grafting and pushing out and aligning the gum segments, creating space for permanent teeth. So that's much older, at 5 to 7 years old. And then we also do bone grafts and fistula repair. Fistula is like there's a hole. Sometimes when the gums don't realign properly, they have a little bit of a hole so that food gets again stuck through. Tip rhinoplasty. We have a lot of parents asking to fix their nose. There's a little bit, almost an obsession. So Vietnamese, they want their kids to have a perfect nose. But again, we don't do that until much later on, until they're at least 9 years old, 6 to 9 years old, or even some plastic surgeons would prefer up to even the preteen or teen years, because the face and the nose is still changing. And then 6 to 9 years is the orthodontics, which Project Vietnam don't do. We just don't have the means or the time. Because of course, you know, just like your kids getting braces, right? They have to be there at least every few weeks, and we won't be able to be in Vietnam that often. Again, phase 2 orthodontics, 14 to 18 years, I won't cover since again, we don't do that. And then 14 to 18 years is jaw surgery to have, again, realignment for some kids who needs it. That's pretty extensive surgery. We don't do that. We usually do just the first few phases. Okay. Okay, feeding a child with cleft lip or palate. There's a lot of questions that I get early on. How do I feed my child? Cleft lip makes it hard for babies to make a good seal around the nipple or the breast. Without adequate closure around the nipple, the infant may have problems producing a suck powerful enough to extract milk from the breast or nipple. Cleft palate makes it hard to create a suction because the mouth cannot be closed off from the nose. Without negative air pressure, a swallow cannot be properly triggered, and aspiration or choking may occur. And there are specialized feeding devices and nipples for these children to help with the feeding. It's a lot softer and it will drip and helps with the air flow. Another trick is to place the baby upright, almost in a sitting position to prevent formula from flowing back into the nose area. Keep the bottle tilted so the nipple is always filled with milk and pointed down and away from the cleft. Babies with a cleft need to be burped more often because they do take in more air, okay? Quiz time. When assessing a child with cleft lip and palate, the nurse is aware that the child is at risk for more frequent episodes of otitis media due to which of the following? Lowered resistance from malnutrition, ineffective functioning of the eustachian tube, plugging of the eustachian tubes with food particles, associate congenital defects of the middle ear. What's your answer? Somebody want to try? Number 1, it's B. Because of the structural defect, children with cleft palate may have ineffective functioning of the eustachian tubes, creating frequent bouts of otitis media. Okay. Most children with cleft palate remain well nourished and maintain adequate nutrition through the use of proper feeding techniques, like we just mentioned. Okay, food particles do not pass through the cleft and onto the straight to the eustachian tubes. So that's why B, ineffective functioning of the eustachian tubes is the reason. Okay, question number 2. While assessing a newborn with a cleft lip, the nurse would be alert at which of the following will most likely be compromised: sucking ability, respiratory status, locomotion, GI function. What's your answer? Sucking ability. Talked about that several times. When providing post-op care for the child with a cleft palate, the nurse should position the child in which of the following positions? Supine, prone, in an infant seat, or on the side. Okay, so palate, we're doing upper. So how would you position the child post-op to help with the drainage if you need to?
Bạn April Dương nói câu B.
B, prone? Let's see what my answer is. B, prone to facilitate drainage. Yeah, so you have to kind of mentally figure out where that drain you want to go, right? Good job, April. Quiz time. An 18-month-old is scheduled for a cleft palate repair. The usual type of restraints for the child with cleft palate repairs are elbow restraint, full arm restraints, wrist restraints, or mommy restraints, meaning the mommy holds the kitchen. What's your answer? Khôi.
April Dương nói câu A.
I thought you April giỏi vậy. Yes, elbow restraints, just to keep the mouth away. Usually the child, if it itches or it hurts, they automatically just want to put their hand in. It's very crucial that we teach the parents to keep the elbow restraints on, because if the child goes in, and especially for the palate, they poke at the palate because it hurts, and it's going to cause a fistula or tear up the surgical wound. Okay. Number 5, a nurse provides instructions to the mother of an infant with cleft lip, with cleft palate, mother of cleft palate regarding feeding. Which statement, if made by the mother, indicates a need for further instruction? Okay. Does this bring back the terror of NCLEX for you guys? Because it does for me. A, I will use a nipple with a small hole to prevent choking. Okay. B, I will stimulate sucking by rubbing the nipple on the lower lip. C, I will allow the infant time to swallow. Or D, I will allow the infant time to rest frequently to provide time for swallowing with what has been placed in the mouth. What do we have? B, the infant with cleft palate would have difficulty feeding despite stimulation for sucking. Okay, so you do want to use a small nipple to prevent choking. You do want to allow the infant time to swallow. You want to allow the infant time to rest frequently to provide time for swallowing what has been placed in the mouth. Okay, there's ability to suck is still preserved. They still know how to do that. It's just that the openings makes it just hard for them to do, and they're more prone to choking. Okay. Need a little break, or we go straight forward? Okay, we'll go straight forward.
Yeah.
Okay. Surgery team role. So if some of you are volunteering with us, this is a little outline of what you will be doing with the team. If you have not registered with us and not coming with us this year, this will help you have an idea of what you're signing up for in future missions. Okay. Admin team. I think I saw someone in the admin team earlier. You're going to help manage and coordinate surgical schedule and staffing logistics for the team, manage patient flow and disposition. Okay, we need you to pull a chart. You're going to pull a chart ahead of time. Ensure all paperwork are done. Ensure essential labs are done. Your job's not to interpret it, because most of you will not be clinical people, but just make sure that it is done. Okay. Pre-op team, if you're in the pre-op team, your job is to verify, make sure that ID match the chart. And before you apply the ID brand, a lot of these kids have similar names. Most of them are Nguyen, so be careful. Prepare patient for surgery. Stay one patient ahead of the OR. So if it's, if the surgery starts at 7, we need that patient ready by 6, okay? If we are working on patient number 1, we should be taking care and get patient number 2 ready. As soon as we're done with 1, then we can just jump right onto 2. Don't let us wait for you, okay? Because then that would really kind of slow us down, and we have a lot of patients this year. Pre-medicate the patient, usually it's Tylenol 10 milligram per kilogram. We like to use the lower end of the range because a lot of our patients are a lot skinnier and much smaller than your average American patients. And plus 10 milligrams per kilogram is a lot easier to calculate in your head. You just move the decimals around. Confirm NPO time, check vital signs and lab results, okay? NPO, I really need to emphasize that with you guys because, again, a lot of our patients are from the countryside. A lot of the parents has learning deficits due to language barrier. We have ethnic Vietnamese who don't speak Vietnamese very well. We have parents who are illiterate. So you're going to make sure that they are NPO just for the safety of the patient, because if they have food in their stomach, they have milk in their stomach, with anesthesia, they're at really high risk for aspiration, which means getting food into the lungs, and they have aspiration pneumonia, and then it's a big concern for their safety. So we will cancel them. And some of these kids waited for, at least for the upcoming mission, they're waiting 2-3 years for us to come and do surgeries for them. So we don't want to cancel them in the last minute, okay? And then during the pre-op labs, if there's any abnormal labs, illness, like say the kids come up with the URI symptoms, make sure you let our anesthesiology chief, Dr. Nathan Lee, know about it ahead of time. And then at 4 o'clock, usually pre-op team is pretty much done. That's when you focus on the family education of the newly admitted patients for the next day. So pre-op team is the first to get to work, the first to be done. Surgery team roles, continuing the education team. You start on Sunday before everybody else and daily at 4 p.m. to educate the parents of newly admitted patients on NPO instructions. Go over what to expect on day of surgery, educate the parents while their child is in surgery on post-op care, using the wound care kit, feeding and pain management, daily round on the ward to assist a post-op family and patients, work with Dr. Chen to communicate with the hospital staff, and visit patients at aftercare facility if they are discharged from the hospital. Okay, so the educating team and the pre-op team will be doing that role. We usually have to do almost like a one-on-one education because, again, a lot of the learning deficits. You can't hold classes, huge classes for everybody to sit in, mainly because we have, again, very different spectrum of patients, those who don't speak Vietnamese, those who are illiterate, and then you have parents from Saigon who are very tech savvy and know how to Google everything up. So OR team, you have the circulating nurse, okay? You need to develop the surgeon preference card early on, talk to your surgeons, see what they prefer for what type of surgery. Hey doc, what kind of sutures do you need for the lip cases? What type of sutures do you need for the palate cases? So what's your glove size? Make sure you know all that ahead of time. And ensure the room is adequately supplied. Ensure that the surgeon scrub and anesthesia is ready to bring the patient in the OR. Help start the IVs, prep patients using sterile techniques, and help drape the patient. Also help the scrub and surgeon gown up. Okay. The scrub nurse, okay, your role is to be familiar with the surgical instruments and supplies, assist surgeon with retraction, suctioning, lighting, control the bleeding, help the surgeon gown up, drape the patient, ensure rapid OR turnover. When it's closer to the mission, I will email the scrub volunteers the instrument note cards so that they can be familiar with the surgical instruments prior to the mission. There's not that many because it's all in the face, so you don't worry about having to learn 100 new instruments, maybe 20, okay? The float nurse, again, we might have people calling in sick because they go out and eat street food. I don't recommend that. We have, sometimes we have a lot of patients and we might have to open up, you know, a fourth team. That's where I'm going to use the floats for. Okay, so you're my jack of all trades. Surgery team role, sterile processing. You're going to help with the surgical instruments. You're going to do the basic washing and supplies of the hospital. So you're going to wash this, you're going to do the first wash, and then you're going to bring it to the hospital central processing so that they can sterilize, put it in the autoclave for us, and then make sure that we have all the supplies for the surgery as we need, okay? So this role is very important because without you guys, we have no supplies. PACU team, your job is to recover the patients and transfer the patient to the PD ward, administer antibiotics for prophylaxis, and help educate help the education team with teaching parents on post-op care. 99% of the time, it's a very happy time where the parents come in for the first time to see their patient, their child after surgery, and see the life-changing changes that we make for their child, and it's very tearful. A lot of crying. The children are usually up and crying and screaming because we just did surgery on them. They're in pain and they're miserable and they want their mom. But you know, there's a 1% chance that with post-anesthesia issues you have to be careful for. Okay, aspiration, respiratory depression. So you gotta almost be on alert at all times because this is where your skills are needed. It's that 1% where the child crashes. Make sure you recognize changes in vital signs early on. Don't wait till the SAT gets to 50 before you start screaming for help, okay? As far as help, Dr. Nathan Lee, our anesthesiologist lead, chief, is always available. Any issues, any concern, let him know. Okay, and if he needs to re-intubate and bring the child back to the ER, then we re-intubate the OR, then we re-intubate and bring the child back to the OR. So you have a lot of support. We do have emergency supplies. We do have the defibrillator. We've never had to use it, knock on wood. We're going to continue to do that, okay? But we do have all the ACLS meds if we need to. And we have never had to do that, knock on wood. Okay. Post-op complications. Respiration is usually the first vital sign to be altered in a deteriorating pediatric patient. Okay, tachypnea, where they're breathing really fast. The causes of that, of course, respiratory distress, fever, hypothermia, fluid volume excess, hypovolemia, and pain. All those can cause the child to breathe really fast. Again, those are just sign of distress. When you see a child breathing too fast, you've got to question what's going on and ask for help, okay? Respiratory, and then we have the opposite, respiratory depression, where the child is not breathing at all. They're taking very slow breath and not breathing enough times per minute to get the adequate oxygenation, okay? And one of the common symptoms are, of course, anesthesia. They're over-sedated. As a side effect of pain medications, again, over-sedation. And pain, sometimes it hurts to even breathe, so they're holding their breath. Respiratory distress causes, okay? Sometimes they look like they are choking, right? and help and seem like they're in distress to help for breathing. Some of the common causes is retained foreign body. For cleft palate, we have the child's mouth open at all time. We're working in the palate. There's a lot of drainage. There's a lot of blood. So we would pack the throat with a throat pack, and the circulating nurse makes sure that you note and alert everybody when the pack is in and when the pack is removed, so that the team is aware that, hey, the pack is still there or not, and that needs to be removed before the patient is extubated, because we don't want the child to aspirate that throat packing into the lungs. And of course, bronchial spasms and bronchial edema. A lot of them cause bronchial spasm, blood drainage going into the lung. Edema, intubation. of the throat. If the O2 line, or you're having a hard time keeping it at 90, any sign of respiratory compromise, always put in high flow O2 by mask and notify Dr. Nathan right away. Don't hesitate. Even if you're not sure, just ask, okay? Where am I? What's the next page? Post-op complications. Aspiration, we talked about that already. Okay, the sponge count's very important to verify that. Okay, just because we're in Vietnam doesn't mean that we let go of our standard of practice. Okay, remember in the States, every needle and every sponge is counted. We're going to do the same thing in Vietnam. Every needle and every sponge needs to be counted, including the throat pack. Okay. Anesthesia causes decrease in gag reflex, and nausea is common side effect. Any gastric content prior to surgeries lead to intraoperative nausea, vomiting, leading to severe aspiration pneumonia. Pre-op nurses must verify NPO status prior to surgery. Child needs to be NPO until they're fully awake. Okay. Tachycardia, tachycardia can be due to crying. The heartbeat's beating fast because they're crying, or they're dehydrated, or they have a fever. So if there's any suspicion, check the temp, okay? Bradycardia is a late sign of respiratory failure, okay? Be familiar with the age-appropriate pediatric heart rates, okay? Okay, post-op complications, fever. Okay, 71% of patients undergoing cleft palate repair surgery will develop fever within 72 hours of post-op. In most cases of post-op fever are benign. Okay, it's probably due to a lot of inflammatory changes that's going on. Okay. So you're going to get a lot of parents pulling you over saying, hey, my child has a little bit of fever. They might just be a low-grade fever. That's normal. Every post-op patient, again, we will put them on prophylactic antibiotics. There's a study that shows children needing cleft lip and palate, particularly cleft palate surgeries, getting antibiotic prophylaxis has a reduced risk for post-op fever, post-op infection, and fistula formation, okay? No oral temperature due to the risk of wound dehiscence. Yeah, I mean, the child just had a surgical wound in their mouth. Don't put a thermometer in their mouth, okay? Hole and do everything we do. Do the axillary or the digital temperature, okay? Patient education on fever management. Don't bundle the child. That's almost a very common Asian thing. The child has a fever. They wrap the child up in a bundle because they're worried about, I don't know what. Okay. Remember to teach the parents about cooling measures. Take the bundle off. It's okay to put a cooling pack on the head. Cháu nó sẽ không có bị trúng gió đâu, right? They worry about trúng gió, so they bundle the child up. Tylenol, again, 10 milligrams per kilogram for every 4 hours as needed for fever over 38C. We're going to be in Vietnam, we're going to use Celsius, okay? Chills, the OR is cold, circulating RNs, make sure to remember to bundle the child. Chills can increase metabolic demand and physiologic stress. Bleeding. Some drooling mixed with blood tinge is expected. Pack URN to notify surgeon or nursing lead like myself if uncontrolled bleeding, I mean the child passing clots. It's very rare that that happens, but if it does, or if you're concerned and you need a second opinion, just let us know, okay? Be very careful to avoid wound dehiscence when cleaning the blood, gentle compression to control bleeding. Wound dehiscence, child may scratch the surgical wound due to pain or discomfort. Make sure to use the arm boards to prevent child from putting the hands in the mouth. Avoid oral trauma with spoons when feeding the child, and of course, no straws. Again, it'll poke right through.
What happens when this kid starts earning loads of money playing video games, even though his mom says he's
Post-op. Every post. Are you? Tylenol every 4 hours is needed for pain. In rare instances when the child has a lot of pain, we do give them some fentanyl, but that's only with the approval of Dr. Nathan. Okay, he will let you know exactly what dose and if you're okay to give it or not. So it's not a standing order for fentanyl. We want to really minimize opioid use in the PACU area if we have to. Okay. What I learned in my experience with the nursing in Vietnam is they are very unfamiliar with the pain scale. You know, the patients just tell you they have pain or not. Okay. You might have a hard time telling them, can you rate your pain from a scale from 0 to 10? It's a very foreign concept to them. So I usually recommend using the flat pain scale for nonverbal infants, okay? How their facial movements, their leg, their activity, their crying, on their ability to be consoled. Basic pediatric nursing there. Okay. Common post-op complications, dehydration is very common due to fever and poor oral intake. Sometimes it hurts to eat, so the child doesn't want to eat. Even when a child goes home, if it hurts to eat, you know, probably give them some Tylenol every 4 hours before eating time. Early management of post-op nausea with the Zofran every 6 hours. We do have Zofran readily available for these children if nausea is an issue.
He gets so much money for donations from the subs.
Sorry, no pause here. Discharge instructions. We have discharge instructions printed out for the parents, and you guys can just read along with them. Again, don't expect the parents to be reading it because, again, a lot of our patients' parents are illiterate. Some basic information that we cover in the discharge instructions is don't use cup or spoon to feed. Don't let the spoon touch the palate or the surgical wound when feeding. Don't let the child chew on anything until wound is completely healed. Don't let the child bottle feed or nipple feed until wound is completely healed. Okay, again, that suction motion can cause wound dehiscence. After feeding, give the child water to rinse their mouth. No hot food or water. Okay, that opens the vasculature, increase the blood flow, and increase risk for bleeding. Week 1, fresh milk, formula, fruit juice, or clear warm broth is fine. Week 2, creams are fine, ice cream, yogurt, plain porridge, jawa, or doan saya, parade food. And week 3, by week 3, they can eat as normally. They do. Okay. And then make sure the parents to notify the doctor if they have fever, anything over 37.5 or 38, uncontrolled vomiting, bleeding or changes in stitches, injury from the surgery. One year we had a child fell off a table and we have to take the child back into the OR and redo the surgery like the day after. It was not fun. Any purulent discharge or foul odor from the incision site, or the pain is unusually out of control. Okay, it's painful, but it's not where the child should be screaming day and night. There's usually something going on wrong. I think that's it. That covers the patient instructions. Oh, one more thing I need to talk about is the post-op care. Bacitracin, if the child has a cleft lip repair, and if we use Dermabond to cover the wound, don't put bacitracin on the Dermabond because the bacitracin will prematurely break down the Dermabond, okay? I think that concludes our class. Unless you guys have any questions, I'm free to discuss any subject you guys want. I know a lot of nurses were asking me about being a nurse practitioner or my experience as an international volunteer nurse. I've gone to Ecuador. I've gone to Ghana, and the last 7-8 years I've been in Vietnam. Okay. Open mic, questions before we conclude.
Hi, chị.
Hello.
Hi. Do you know how many patients we have so far?
So far, we have 78.
Wow.
And these are the patients that had already been screened by us, by the nursing surgeon and anesthesia team, to make sure that they qualify, because we don't want to waste our time and their time by them having to come so far for us to say that we either can't do the surgery for one reason or another.
Okay.
So not every patient who applies will get accepted. We do have certain criteria. We have patients who are unrealistic about how the outcome's going to look. You know, they want their child to look like a beauty model, and we're like, no, that's the best that we can do based on the circumstances. We don't do orthodontics, and we don't do more of the bigger craniofacial grafting, jaw realignments, and those are too much for us to handle in a week-long surgery mission, especially when we have so many other patients that need our help.
Yeah.
We also don't take some of the very sick ones with heart issues, because again, they might need ICU care. So we do accept them on very tight circumstances. I mean, we would need an echo to show that they have good heart function before we approve. So because of that, not every patient that signs up will be accepted. But so far, it looks like we have about 78 patients that are already accepted.
Yeah. And
that's a
you
lot.
said
That's a lot, considering our mission is not until November. They still have a few more months to apply.
that sounds like a lot. And you say last time that we have 3 surgeons, right?
No, we have, right now we have 7 surgeons. They're going to make up 3 teams initially to start. So each table has 2 surgeons to work together. And then depending on how it goes or how many patients, we might split them up and make it 4 tables. So 4 continuous table, I mean, just boom, 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 boom. Very short turnaround time. So everybody has to really do their part. So it's very important that I'm hoping that the 2 classes that I host, the volunteer nurses have an understanding of what's to be expected.
Yeah.
Okay.
Yep.
Any other questions? Throw them at me. With me. Doesn't have to be with the surgery team, just international nursing in general.
Is this event annually?
Is this mission annual? Yes, we before COVID, we were going every year.
Yeah, thank you, Jay.
And we hope to come back and do this every year. We've been doing this every year since 1996.
Oh, wow.
Yeah. So that's why we get things really streamlined. We've been working on the core team. We have a lot of, major core team members that dedicate a lot of time. Nursing team lead, anesthesia team lead, surgery team lead, admin team leads. We meet once a month, about 6 months to a year before the surgery, to get this all lined up, to get the surgeons, recruiting surgeons, figuring out what day we can go, and then recruiting nurses, recruiting patients, screening the patients beforehand, procuring supplies. When you go to the mission, when you are on the mission day 1 and you see all the chaos and you wonder why it's so chaotic, please understand that it took us a year to even get to that point. It's a lot of preparations, permitting, outreach. I mean, a lot of these patients live at the borders of Cambodia and Laos and up in the highlands, in the villages where they don't have internet access. So it's not like you can make a Facebook post and get everybody. So it's a lot of work to get that. But Project Vietnam has been around a long time. If not as long, if not longer than Operation Smile, doing what we do. So we do have the connections and the dedications to make it run smooth, okay?
Yeah, I hope I can join you guys next time.
I do recommend that when you join, you have at least 1 year nursing experience.
Yeah.
Because again, we are functioning at a very high level in a very fast pace. You can't not just come in as a brand new grad with no work experience. We might take 1 or 2 students or newly grad to do more of the administrative role. But I think your experience will be best maximized if you have at least 1 year of nursing experience under your belt. I mean, even the experienced nurses, they come in and they look like the first day you can tell, tell Hinan to take a look at everybody's eyes, okay? You can tell who the new volunteers are. Their eyes are like this big because it's like there's so much going on that it's almost
Probably me,
overwhelming.
G.
Huh?
Probably me.
Yeah, it's organized chaos. It's gonna look like it's chaotic, but it's very organized chaos. You know, we try to organize this as much as we can. We're not going to be 100% perfect, and again, every year is different depending on the hospital that we have, and what they allow us to do or how accommodating they can be. You know, so you have to be almost flexible with that. And know your role and do your role well and be dedicated, and the patients need you, okay? Don't come in with unrealistic expectations, okay? When you apply, we look at your CV very closely to see where you best fit into the role, okay? You cannot be, you know, a nurse in non-patient care and expected to be doing scrub work or PACU. I have nurses in previous year who were upset at me because they had this vision that they're going to be like scrubbed in to do surgery, but they've never ever worked in the OR. That's not allowed in the States. It's not going to be allowed in Vietnam. It's not safe for the patients, and it's not right for the patient. It's not safe for you as a nurse. Okay.
Hey.
Any other questions?
Oh yes, I do.
Anybody have any other question?
I have a question.
Mm-hmm.
Have you finalized about what hotel are we staying?
Not yet.
Okay. And at the end of August, you still expect us to pay that accommodation fee or whatever, the land fee?
Yes, you should get an email from the admin team to administer that.
Okay. Thank you, Jade.
So if you have not, you should be getting an email from the admin team to go over the logistics and frequently asked questions and what to expect it as far as visas and then cost. Okay. A lot of nurses ask, well, we're already volunteering our time and our talent. Why do we still have to pay for ourselves? Because Project Vietnam is a nonprofit organization. Everything we do is based on donations. And if you've ever tried to fundraise, it's very hard to fundraise. And we barely just have enough to pay for the expenses for the patients. We have to rent the OR, rent the PACU, rent the pre-op area. We have to contract with the hospital to do the lab work for us and the night staff for us, to the nursing staff, to take care of the patients at night when we're asleep. So those all really add up. We pay for the room and board for the patients for the week while they we pay for the room and board for the patients during the week that they're with us while they're waiting for surgery and after they have the surgery, to make sure that they're safe before they can go home. We pay for their food. all the medications that we give for them, and we pay for the supplies, the equipments, and what else? Oh yeah, we pay for the transportation cost of these patients and going from the highlands everywhere to come to deal with us. So those really add up. It comes up to be, I think, several. If you add in transportation and everything, I think it's about $400, $200 to $400 per patient. So from all those,
Okay.